together.
So now we have Dr. Kumudini here. She will give her keynote address. Dr. Kumudini is heading SGPGI Lucknow Ophthalmology Department. She is her area of interest are neuro-ophthalmology beside anterior segment. So she will be speaking on occult giant cell arthritis. We have got one more speaker, Dr. Kasturi. I think he should be joining us any moment. He's there in other after her talk. Dr.
Good morning to all. So I would be talking about the occult giant cell arthritis, which is also called the silent giant cell arthritis. And we have, among all the physicians and ophthalmologists, we have a misconcept that giant cell arthritis doesn't exist in India. It's known that it's more common in Caucasians, but in non-Caucasian population, it is not rare but uncommon. And what is this? This is a well-established identity. And we have a review article by Dr. Harry in our January 2021 issue of IGO. And he says it's a well-established entity where there are the sign and symptom of giant cell arthritis are absent. But these patients have ophthalmic complications and a temporal artery biopsy positive. And the ESR and C-reactive protein in majority of the cases is raised. But the normal CSR and the absence of systemic sign and symptom of giant cell arthritis doesn't rule out the diagnosis of GCA. So we have to keep this in mind because these are the cases which present primarily to the ophthalmologists. So the ophthalmologists are in the front line to diagnose this entity, and by early diagnosis and management, we can prevent the irreversible visual loss in the other eye. So we know giant cell arthritis is a chronic granulomatous vasculitis of unknown etiology, which affects mainly the large and the medium-sized blood vessels, which have an internal elastic lamina. The ophthalmic features are mainly due to the involvement of posterior ciliary artery or the branches of ophthalmic artery. The ischemic anterior arthritic type of AION is the main presentation of these cases. And sometimes they have a diplopia because of the muscles, because of the blood vessels supplying to the muscles involvement, or CRA occlusion or ciliary artery occlusion. And sometimes they have a branch arterial occlusion also. But these are the other rare many ophthalmic involvement in GCA. The main involvement is the arthritic anterior ischemic optic neuropathy. So the GCA is a vasculitis more than 50 years of age. And as I said earlier, there's a common belief that GCA patient should have a systemic sign and symptom and the raised ESR to make the diagnosis, which is not seen in some subgroup of the cases of GCA. And occult GCA is a clinical entity where the systemic symptoms are absent, but they have a positive temporal artery biopsy and with the raised inflammatory markers in most of the cases. And these are the cases which have a mainly ophthalmic involvement. So my first case is a 60-year-old male who presented to us with sudden loss of vision in the right eye for one day. And he was a known case of diabetic mellitus and hypertension, ischemic heart disease, which was there for last 7 years and which was under well controlled. When we examined the patient, we found that the visual acuity in the right eye was no light perception and the left eye was normal. He had a afferent pupillary defect in the right eye. The fundus showed the pallid disc edema in the right eye. Seeing the pallid disc edema and the sudden visual loss in 60 years of male, we made a diagnosis of arthritic type of anti-ischemic optic neuropathy. When we palpated the superficial temporal artery, they were palpable but non-pulsatile, and there was a mild tenderness over there. We send the blood sample of the patient before starting the IV methylprednisolone for inflammatory marker, which we should do because we know the steroid intake may alter the values. And we did the frontal superficial temporal artery biopsy, the frontal branch, and we did it the third day after the starting the antibiotic. Immediately on the same day, we started IV methyl because the other eye involvement is known may happen in the 1 day to 6 months. So after giving the 5 days of IV methylprednisolone, we switched over the patient to the oral steroid. And usually we taper the steroid according to titration. We titrate the dose of the steroid with C-reactive protein and ESR values. and usually it takes 3 to 4 weeks to start tapering the steroid dose. And the patient as a diabetic, his blood sugar was not getting, it was going high on steroid. So we started adding the methotrexate as a steroid sparing medication. But later on, methotrexate, the patient had a pneumonitis and he was put on tocilizumab because interleukin 6 is always increased in the patient, these patients. And biopsy was very much suggestive of giant cell arteritis, where there was a inflammation or infiltration by the inflammatory cells in all the 3 layers of the blood vessel. Second was a 70-year-old male, and he was also a diabetic and hypertensive. He also presented to us with a sudden loss of vision in the left eye. Was very unfortunate patient because he had lost the vision in the right eye 6 months back, and he went to the neurosurgeons and neurologists. And neurologists, they always deny that it doesn't. Giant cell arteritis is very rare and it's not possible. He made a diagnosis of optic neuritis and treated him, but luckily he treated him with the steroid. So immediately he didn't have the involvement of the other eye with the GCA. But when he came to us, we examined both the eye, and we found there was no light perception. And one eye he also lost because of the arteritic type of AION in the right eye. When he came to us, he had a pallid disc edema in the left eye, again because of the history and considering the age and the pallid disc edema, we suspected it must be a case of giant cell arteritis, though he didn't have any signs and symptoms. And when we palpated superficial temporal artery, they were palpable, non-pulsatile, and they were non-tender because he had already the steroid. The inflammation might be in the subclinical stage. And the blood levels where inflammatory markers were highly raised. So we did the biopsy again in this patient, and it came positive, and we treated him with the ethylmethylprednisolone and the oral prednisolone. But as we know, it results in irreversible visual loss, hence the early diagnosis is important. So this patient, as he did, his inflammatory markers started decreasing on steroid, but he didn't get his vision back. So he stopped coming to us for follow-up. The third is a female. She was 65 years of female, and she was again diagnosed by neurologists as a right eye optic neuritis because she had a sudden visual loss, and she went to them. And she had a holocranial headache, which was there for a long time. Headache can be one of the clinical presentation, but that is a localized headache, which is a new onset, which should raise a suspicion of GCA in this patient. But this patient have a holocranial headache, and as she had given the course of steroid by the neurologist after making a diagnosis of optic neuritis, and she came to us with the visual acuity of no light perception in the right eye, and she was not in the age of optic neuritis where we should suspect. We know after 50, it's a vasculopathy causes most common for a sudden loss of vision. The pupil was a pupillary defect there was, and the fundus again showed in this pallid disc edema, which was not very severe as in the early 2 patients because she was already on the steroid for last 3 weeks. We did go ahead with the biopsy because she was on the steroid, but I think we should have gone because in Harris says even after a period of 1 month, the inflammation, signs of inflammation are still there in the superficial temporal artery biopsy. So we should do if we suspect it's very suspect that giant cell arteritis. Even after the patient is on the steroid for 3 to 4 weeks, we can go ahead with the biopsy, and positivity is high in this case, in spite of having a steroid for a week, for a month. So this patient have a raised platelets and inflammatory markers were also increased. And the thrombocytosis is one of the features of giant cell arteritis. And because on the basis of the blood examination, inflammation, and fundus examination, and again the history of sudden visual loss in the 70-year-old female, we made the diagnosis might be a case of occult giant cell arteritis. And as I said, we postponed the biopsy thinking that she was already on the steroid. And we put her on the steroid thinking to prevent, because involvement of the other eye may be within the period of 6 months. And these patients, once you make a diagnosis of giant cell arteritis, we have to keep them on the steroid for a period of 1 year or 1.5 years or even 2 years. It's a self-limiting disease. So According to Harry, he says because he himself is a Dr. Harry himself is a case of occult giant cell arthritis, and his siblings are also there. And he says that these patients should be maintained on the low dose of steroid, like 5 milligram per day, for a period lifelong. And he himself is taking the medicine of steroid for a lifelong for his GCA. But the rheumatologists, they have opinion that they give it for a 1 to 1.5 year or 2 years period. So we kept this patient on 1 milligram for steroid per kg of body weight and tapered it according to ESR and C-reactive protein levels, and tapered it over a period of 6 to 7 months, and we kept her on the maintenance dose of 5 milligram per day for another period of 6 months. So we can say that giant cell arthritis, systemic inflammatory vasculitis of medium and large vessels, unknown etiology, occurs in the elderly age group of more than 50 years. And it is supposed to be rare in Indian scenario, but not uncommon. And it is because of this impression, it is underdiagnosed or misdiagnosed, and early diagnosis management is important. And if we see in our 3 cases, is required to prevent this irreversible visual loss in the other eye. Overall, 73 cases have been reported from India, from different parts, from the west, south, and the north part of the India. And what we have comparing the results from India, okay. So it is important to know that occult giant cell arthritis, as these cases, they come to us, present to us primarily, and ophthalmologists are in the front line to diagnose, and early diagnosis and management helps to prevent the irreversible visual loss.